I think बेसी काम करे से केबे एडमिट करेनी कि हमें बेसी काम करू छु
नहीं एडमिट करू न करू सको ता ऊपर काम माने कंसंट्रेट ग्रेविटेट करे काम ता
so Keshav is one such person
नहीं सेमिति किछि नहीं इनफैक्ट आज हमर गोवा इंस्टीट्यूट ऑफ मैनेजमेंट तांकर दी दिन आ गोटे चलची एम्प्लॉयमेंट ऊपर गोटे कॉन्फ्रेंस ता so I had a keynote address in the morning 12 सुधा so I was little exhausted today तापर मु कहले जे जेहेतु अमरेंद्र राव कहचंती मु जेमिति सुनिया पड़ियो बोली so बहुत अपन टॉपिक था इंटरेस्टिंग टॉपिक है माने सिखला वाला टॉपिक हम नाम जोटर किछि जानिनु
ना
it's very important to know about these things
basic stuff कुछ गोटे पेपर नो नहीं just I'm synthesizing the couple of papers and the experience that we garnered over the years so will we call it layman पाइन जमती कि no technical jargons involved
so Suresh he is there or he has gone to Delhi
he is in Delhi na
acha
so April the last asthi the May 1st join kala ki kaun May 1st या April 30th से release होला सेठू मैं join करछो
अच्छा
May 1st join कर
तो अमरेंद्र अपन सब तासी गलानी प्राय ना
again so I think we can start well देखो जी हमरो सचिदानंद सर जॉइन करबार थिला से जॉइन करले कि नहीं माने हमरो पुआ हमरो Pattnaik पुआ yes I think he has joined yes
आरंभ 4टा बजला
sir Sachidanand sir, please join with us. I am sending a request. Yeah, I think I've joined. Sachidanand sir, you can put your camera on and unmute yourself. Sachidanand sir, you can now put your camera on.
तळे लेफ्ट रे आड़ अछि माइक ता अछि माइक पछरे गोटे स्टॉप वीडियो टा अछि
वीडियो
आज्ञा आज्ञा सो स्टॉप वीडियो लगे सेटा से वीडियो रे हां असला आज्ञा अच्छा नमस्कार नमस्कार
नमस्कार so we shall now start okay so namaskar to all and good evening and I welcome all of you to this important lecture that is Professor Kshetra Mohan Pattnaik Memorial Lecture, and this will be the 9th lecture in honor of Professor Kshetra Mohan Pattnaik, and today is the 94th birth anniversary of Professor Kshetra Mohan Pattnaik. So let me share a PPT with all of you. Small one. Yes. So Orissa Economics Association welcomes you all, and we have with us Professor Keshav Das, who is the president of Orissa Economics Association, and the main attraction of today's event, Professor Umakant Das, who is the director of Institute of Rural Management, Anand, Gujarat. No, you will be getting more information about the speaker very soon. And also with us we have Dr. Sachidananda Pattnaik, who is the son of Professor Kshetra Mohan Pattnaik. And to give a brief introduction about Professor Kshetra Mohan Pattnaik, Professor Kshetra Mohan Pattnaik was born on May 10th, 1928 in Chhatrapur, Ganjam district of Odisha. But his native place is Rengala, that is near Delanga in Khordha district. Earlier it was in Puri district. And Professor Pattnaik died on May 8th, 1999. And you can look at his education, that he obtained his education from like high school education from Chhatrapur, then intermediate education, then in Uttal University, then BA from Maharaja's College, Paralakhamandi, MA in Economics from Banaras Hindu University, and Master of Arts from Stanford University, USA in 1958. And then he obtained his PhD on monetary policy and economic development in 1965. And he has served at different important places. In fact, there are many of there are some of his assignments that he had taken up. And in fact, when we were students, we have also studied a book on monetary economics. Pattnaik was a very good teacher and researcher, and his contribution to Orissa Economics Association is also very, very significant. And he was also the president of Orissa Economics Association. And in fact, I hope you might have seen this dictionary, that this dictionary, Oxford Dictionary English and Odia, was edited by Professor A.M. Pattnaik and B.K. Tripathi, published by Kalyani Publishers. And that was all about in brief about Professor Kshetra Mohan Pattnaik. And coming to this specific lecture, the lecture in honor of Professor Kshetra Mohan Pattnaik started in 2014 with the financial support of his family members, basically his son, Dr. Sachidananda Pattnaik, who is with us today. And the first lecture was delivered by Professor Pulin Bihari Naik from Delhi School of Economics. And this is the 9th lecture in memory of Professor Kshetra Mohan Pattnaik. And today, Professor Umakant Das, director of IRMA Anand, is going to deliver the talk. So with this, I basically conclude the remarks, and I now would request the president of Orissa Economics Association, Professor Keshav Das, who is currently working at Gujarat Institute of Development Research, to preside over the meeting. And I would also request Dr. Sachidananda Pattnaik to give his remarks. So it's over to you, Kshetra, and please preside over the meeting. Yes.
Thank you very much. It's a great privilege because it involves Professor Kshetra Pattnaik, about whom you spoke, and we always felt very proud of him. And it is also equally very, very privileged occasion for us to have Professor Umakant Das, who actually I'm really, really looking forward to listening to him. I've heard a lot about his work, very, very serious scholar. So we all are waiting to listen to him. But just before that, maybe we can make a little request to Dr. Sachi Pattnaik if he wants to say a few words, and with that we can proceed then. Dr. Sachi Pattnaik, please.
Namaskar, respected President and Secretary, all members of the Orissa Economic Association, and especially today's guest who will be delivering memorial lecture, Dr. Umakant Das. As a son, I have nothing to say except expressing my heartfelt gratitude to all of you for having organizing this function right from 2014 till today. Previously, it used to be organized in the Orissa Economic Conference. Now it has been on his birthday. I am very happy, and I hope this will continue forever. And I am grateful to all of you. Except expressing my gratitude, I have nothing more to say. And I hope the younger generation will learn more from these lectures and they will be benefited. Thank you very much.
Thank you so much, Sachi Bhaiya. I also know you in a very personal capacity, and it's very nice that you are with us. And of course, we always valued teachers of high quality, valued people who have contributed to the society, and Professor Pattnaik belongs to that category. With that, so let's now move on to Professor Umakant Das, the special guest and the speaker of this evening. About Professor Das, let me sort of give a very, very brief sort of introduction. He's currently the director of the Institute of Rural Management in Anand, IRMA as it is known. And he, as I was speaking to him just before this event was formally starting, so he has been really several students and faculty members that I've interacted with, in fact, spoke very highly of him, that he has in a very short time made the institute very, very dynamic. So it's a great thing to know. And before joining IRMA, he was the professor and head of the Department of Humanities and Social Sciences at the IIT Madras, and he was also the adjunct professor at the IIM in Tiruchirappalli. He is sort of, what I gathered, he's basically, he's sort of one of the major areas of his work relates to health and health systems, health economics, and health management. And in that, so he holds what is called a Dean's Honor Scholarship of Tulane University in US. I understand it's a very, very prestigious scholarship that he held. He also holds a PhD in Applied Economics from the IIT Kanpur, and he has nearly 2 decades of experience with several institutes of national and international repute, like the IIT Madras, Uttara University in Malaysia, BITS Pilani, and also he has been a visiting lecturer and professor in several other institutions. His broad areas of interest lie in macroeconomics, financial economics, health economics, financial management, energy economics, derivative markets, and so on. He also pursues his questions on equity, efficiency, and risk protection, I think being sort of largely in the domain of public policy, if I may say so. And he has sort of been very closely associated and led projects with sort of organizations like the DFID, Rockefeller Foundation, WHO, Access Health International, and so on. He's also involved in collaborative research projects globally through CREHS, GHLC, and sort of worked with sort of scholars, work with practitioners in countries like South Africa, Thailand, Bangladesh, Ethiopia, Nigeria, Tanzania, Kenya, and the UK. He's also very, very heavily published scholar. There is nothing surprising about that. And I'm personally very happy that he has also been a kind of in some sense, a public intellectual, and very often joins in discourses, debates relating to such important topic, mainly health management, and health access. And today's theme, I suppose, relates partly to that. And this is a subject, as I was telling him, not everybody probably knows very well about, but I think this is a subject which is of tremendous importance in current times, especially when we are still just 1 foot out of the COVID crisis. Thank you very much, Professor Das. We are just eager to listen to you. Thank you.
Thank you. Thank you very much. Thank you. Good afternoon to all. Dear Dr. Sachidanand Pattnaik, Professor Keshav Das, President of Orissa Economic Association, Dr. Amarendra Das, Secretary of Orissa Economic Association, and other dignitaries who joined this particular talk virtually. I see my guru, Professor Lenka, is already there, and my friend Niyati Padi is also there. At the outset, I would like to thank the organizer for giving me this opportunity to speak on this occasion, on the occasion of the person whom we admire and whom we closely followed and got inspiration from his writing and his works and activities. I think I have one thing in common with Professor K.M. Pattnaik, though I've not seen him. I played in the field where he was studying in the Pattnaik College. So that is what I can correlate. And my uncle, who was a staunch follower of Professor K.M. Pattnaik, and that is how I would say I came to economics. So I'm privileged. I feel privileged and honored to speak on this occasion. Currently, as Dr. Das said, I'm working in the Institute of Rural Management, which started in 1979 with a sole vision to professionalize the organizations which are working in the rural areas. And which is going to, I think, Dr. Kurian, he realized the importance of professionalizing the institutions which are working for the rural people. And he believed that women empowerment, other things are going to be the outcome of such professionalizing the institutions. So I've joined these institutions 15 months back. And I think I find this place a wonderful place to work with. So today, what I'm going to talk about is transitioning towards a universal healthcare, which we call UHC in India, and dichotomies and distortions. I'm not going to talk about a particular paper. This is basically going to be a summary or synthesis of the works that we have undertaken in the last 2 decades. With my fellow researchers, with my research scholars who helped me to understand the area better and who could able to help me even appreciate the problems and issues that we are confronting in this particular area. So that the outline of the presentation is going to be as follows. Initially, I'm going to just sort of a salient features of the Indian health system, to contextualize where we are compared to other countries, developed countries and developing countries, and the recent government initiatives, which are in a way to move towards universal healthcare, and the findings of the studies which we have undertaken as researchers, and also evidences from the literature, from other studies which were undertaken by our fellow researchers, which would mainly highlight issues related to access, utilization, awareness, and quality of care that is being delivered by the facilities or Indian health systems. Could be private facilities, could be public facilities, or could be any other facilities. And kind of a hardship which we undergo or people suffer when they get some kind of ailment. And sometimes we might have read from newspapers and might have heard experiences of our friends, relatives, and other acquaintances, how much expenditure they incur, out-of-pocket expenditures, and how catastrophic that expenditure becomes. Even one ailment sometimes pushes households to below poverty line. That's the kind of hardship we see or encounter in this particular sector. And governance issues related to governance, issues related to supply side constraint, which are a sort of a major, say, blocks for our achievements of universal health coverage. Then if we want to move towards universal health care by 2030, or health for all by 2030, where we are now and how much effort we need to make. And in that context, I'm going to talk about how much fiscal space we have, and whether the government is making the required effort, and whether they have the sufficient space, or what kind of initiatives or inventions in financing they are making, or provisions they are making in order to reach UHC by 2030. And the possible channels of generating fiscal space for health in India, and then the trend, what we see over the last 30 years. And of course, then some of the concluding observations. So if you take the salient features of the Indian economy, I think most of you are aware. This is just a reiteration of some of the issues. Of course, we are doing relatively good, or we are relatively well positioned as far as the nominal GDP is concerned. We are currently the sixth largest economy, or if you take the purchasing power parity, we are the third largest economy. And we are relatively doing good as far as our sense of movement. If we see that is the sentiment of the investors, we have crossed 60,000 mark in 2021. Of course, today it is relatively, it is down because of the oil prices and uncertainty because of the Ukraine-USSR Russia war. And as far as the business, the doing business global ranking is concerned, we have relatively improved our position from say 142, which we had in 2015, to close to 63 position in 2019. So that's a relatively significant jump for a country like India. And on the one hand, economically, though we are stabilized and though we are fine, but on the other hand, you will see millions of people still have no access to, or at all, to good health care, or we have limited fiscal space, which we are going to unpack in greater detail as I go along. Currently, the government expenditure to GDP ratio is close to 11.37 in 2017 World Bank data. Or health expenditure, if you take, hardly we are in a position to, or we are spending close to 4% or less than 4%. And our out-of-pocket is very high compared to even our neighbors or other developing economies. Close to 65% of the expenditures are coming from our pockets. So when we talk about the universal health coverage, we talk about the people, services, product, finances, policies, informations. So these are the things which, some of the things which we are going to discuss. So if I see the health system indicators of India, as I told you, India's per capita expenditure on healthcare is one of the lowest in the world. Hardly we are spending a little over 1,042 to 1,753 between 2013-14 to 2017-18. So though it has slightly increased, but still it is much lesser than what is required for an economy like India. Currently, we are spending 1.35% of its GDP. Though the various committee reports have recommended at least to go up to 2%, we are struggling and finding it very hard to reach somewhere close to 2%. The government health expenditure as a share of total expenditure again has marginally increased from 3.7% to 5.12%, which you should compare to other developed countries is nothing, whereas other countries, they spend close to 15%, 16% of their GDP on health. The government's fiscal effort measured as the proportion of total government expenditure spent on health again identifies India as a low performer. The out-of-pocket private spending dominates with 65% of spending of all health spending from private sources. Again, this is one of the highest in the world. So just to say contextualize, again, if you see, compare with the other countries, developing as well as developed countries, be it the current health expenditure or be it out of pocket expenditure. If you take the recent data after 2018 released by the World Bank, so you'll see in current health expenditure, as I told, we are just spending 3.4%. Whereas if you take a country like, of course, we even if you don't compare with the United States, which spend 16.89%, other countries like Brazil or Switzerland or Canada, you will see they're spending more than 10% of their GDP on health expenditures. Out of pocket, on the one hand, you will see countries like Germany hardly less than 12% or 13%. They are it is borne by the households, it is borne by the individuals. In a country like India, we are bearing 62.67%. Even this is much more than what our neighboring countries like Sri Lanka and Pakistan, they are incurring. Physicians, so coming to the infrastructure that is available in Indian health system, physicians, if you see, again, our the number of physicians available per 1,000, which is the indicator we use to assess the readiness of the system. In India, we have hardly 0.69 per 1,000 population. Whereas if you compare it with be it in United Kingdom or be it Russia or be it any other kind of developed country, Switzerland, it is around 4.5 per 1,000 population. So be it the professionals or be it the capital like hospital bed, again, we are nowhere compared to other countries. Hardly we have 0.47 beds available per 1,000 population. So we might have seen the burn that we have experienced during COVID, the lack of the infrastructure. The outcome, some of the intermediary outcomes of health, again, if you see the mortality rate, ours is relatively higher compared to, say, similar countries. Ours is 28.3 for 1,000 live births. Or if we take the contraceptive prevalence, etc., which are again preventive, again, our rate is much lesser compared to other countries. So these are, so when we talk about analyzing the health system, this is the standard WHO framework which we use. Of course, as economists, always we see what is input and what is output and what is a black box that we are going through in order to get the overall outcomes. So the 6 building blocks of the health system, generally the service deliveries, health workforce, the information, data and information that is available, which are going to be used for taking decisions. Medical products, vaccines and technologies, availability of all these intermediary inputs. Then, of course, financing, which is something very important, which we are going to highlight here. And of course, and the last but not the least is the governance and the leadership. Basically here, when we talk about the leadership, whether there is a political will and how much buying the political parties has about improving the health status or improving the health system. So the moment we have political buying and they give more priorities towards the health, you see how the events like Swachh Bharat and other schemes they could be able to increase their uptake and coverage. So the major issues that we come across in the health system is the access, coverage, quality of care that is being offered by the health system, and safety and security. So of course, when we talk about the safety and security, it's basically We talk about financial security, financial, not only the security and safety of the lives, but also how it is going to be financed and the services are going to be accessed. So all these basically leads to improved health. So when we are accessing or evaluating or assessing the health system, we see how responsive the health system is. It's no longer the supply-driven market. We have to be careful. We have to respect the preferences of and perception of the clients or the customers or the households, and whether we are concerned about their preferences, about their perceptions. That's basically what we expect from a good health system. The health system has to be not only improve the efficiency, not only minimize the or improve the financial risk protection, but also it should be responsive. I should respect the preferences and requirement of the households. So when we talk about, so in the last couple of years, and the last 7-8 years, the government has, or if you take the post-liberalization, government started giving more some sort of importance to the health sector. Of course, we are through 5-year plans. We have been giving, we had a constant focus for the sector, health sector, but it was not getting the right kind of impetus. We can say the financial support and the direction. So in the last couple of 10 years, if we analyze, we have very important interventions which the government brought. It could be, we can say, the Ayushman Bharat universal healthcare coverage, which was introduced by the government in 2018, where those who are the vulnerable section or below poverty line, or the beneficiaries who are eligible for this scheme, they can avail up to 5 lakh, cashless benefit per family per year, which covers the secondary as well as tertiary care hospitalizations. Of course, if you take up to July 2021, close to 1.96 crore hospital admissions or patients got benefited, close to 24,315 crores. That shows the volume of or the size and capacity of this particular scheme. Today, just I was checking the data as of now, or as on today, close to 311.27 lakh beneficiaries, they receive free treatment through this particular scheme. And similarly, other schemes you would see is there are schemes like ensuring good health of mother and child. A lot of pregnant women and child got benefited through these specialized schemes or interventions which are introduced by the government. Be it the Posan Abhiyan to ensure proper nutrition. So because health is not, it's also in a big way linked to nutrition and other amenities that we are living. So ensuring affordable and quality healthcare. Close to 1,084 essential medicines were brought under price control regime, giving consumers total benefit of more than 15,000 crores. Because of the affordable quality healthcare or the particular policy, the price of cardiac stent, you can see, reduced by 85%, and price of knee implants reduced by 69%. So these are some of the benefits which has directly been enjoyed by the households. So similarly, attempts were made to improve the quality and affordability of the healthcare through Pradhan Mantri National Dialysis Program, and eliminating disease one dose at a time, so which we called the Mission Indradhanush, which using this we have almost 551 districts, and now it has, because of COVID, of course, it got affected, but I think yes, very soon the government is hoping to at least cover 80 to 90% of the districts of the country. Similar attempts were even made to standardize the healthcare professionals through Allied and Healthcare Council of India. So all these are some of the attempts which were made specifically to reach or to achieve or to attain universal health coverage. So when we talk about the universal health coverage, basically we have the 3 dimensions that we examine. Whether it's basically health for all, whether the entire population is covered or not. So basically we question who is covered and what services are covered by the system, whether they are getting some specific ailments are being covered, or the entire all gamut of the ailments are being given or offered or being provided to the households. And when we get services, how much protection, financial protection we get. So basically, how much people are bearing from their own pocket, and how much financial protection they are getting. So if we further unpack it, it's basically going to be a sort of a two-layer. You will see not only we are talking about the direct cost, there are also, particularly in the sector of health, a lot of indirect cost, and we can even take the loss of income. It's opportunity cost of falling ill, and sometimes even I might not fall in, but because I'm accompanying the patient, sometimes I have to lose my income. So those are the kind of sacrifices or hardship or cost we incur when we seek treatment. So as a system, it is the responsibility of the government, or it is a responsibility of be the state governments or the central government to provide as much as possible. So if we want the block to expand, so that we reduce the cost which are borne by the households or the patients, we want to include as many services as possible, and we want to extend to as many people as possible. So though sometimes we say the public facilities are open to all, it's not that all the facilities or all the services are available. Though technically we say, yeah, it's 24/7, all the cares are available, but you will see people are not going because of various reasons. It could be because of distance, or it could be because of the quality of care, or it could be because of the waiting time. So in the recent past, we have done a lot of research on be it out of household economic burden on non-communicable diseases or communicable diseases. We also studied, of course, I'm just taking a couple of papers, citing a couple of papers here, but otherwise we studied the access, we studied the equity, we studied the utilization of the public facilities, and we did talk about the level of inequality and the role of governance indicators in the coverage of reproductive material, maternal and child healthcare services, and horizontal inequity in self-reported morbidity and untreated morbidity in India, which are published in various international and national journals. So for example, if you take geographical accessibility and spatial coverage, modeling a public healthcare network in rural and remote areas. As I told, I'm not going to focus on one particular paper, just we want to use this paper to summarize the kind of problems that we encounter, or dichotomies or limitations that we have as far as supply side constraints are concerned, as far as the demand side issues like awareness. People are not, though there is a felt need. When we have gone to villages, when we have interacted with the household, we have seen the kind of hardship they were undergoing. They do not know where to go. But it could be sometime because of the distance, the miles to cover, or it could be they are not sure whether the services would be available or the doctor would be available when they reach or they commute or travel 10 miles or 15 miles from their houses. Or sometimes it could be they're not sure whether that particular ailment will be available in that particular facilities. So here, just I want to highlight one particular study, which is again interesting and which has not changed even the last couple of years. So this particular study is about the Ayushman Bharat, this Pradhan Mantri's Jan Arogya Yojana, which, as I told you, was introduced in 2018. And we have done the study in 2020, initial 2020, in the 3 states, Bihar, Haryana, and Tamil Nadu, to question like what are the level of awareness of various features of the PMJY amongst the beneficiaries, and what are the various dimensions of the process of creating awareness, beneficiaries, identification and registrations, and the supply side constraint in the awareness creation and registration process of the program. So we have interacted with the people, and we have interacted with the officials, and we have studied the documents that are available with the website and with the government departments. Some of the striking findings. So even though we say examples, when initially when the scheme was introduced, basically they were sent letters from the Prime Minister's office or from the central government who are entitled to get the services or the free services under the Prime Minister's scheme or social health insurance scheme. So surprised to know letters were not distributed due to lack of workforce. So most places it is distributed by locals, and for distributions, even they were charged, the money were collected from the beneficiaries, poor beneficiaries, for distributing the letters. No additional information provided by the locals and the ASHA workers. So it's basically those are most of the households, though they gotten the certificate or the letter or the card, they do not know how to use the cards. They do not know what kind of services are going to be available, or they can use using this Ayushman card, or which are the empaneled hospitals, and all these are the major issues which we have found. Which of course, again, using the key informant interviews, we try to triangulate, because we just you have to see what are the supply side constraint, and we also observed the hospitals, the chaos, to find out, triangulate some of the things. So basically, you'll see the major challenges that we encounter even today, even after 4-5 years of introduction of these schemes. The awareness creation, be it the PMJY scheme or be it any other schemes of other welfare schemes which are being launched by the governments, be it the state government or the central government. The awareness creation process is for a large national flagship program such as PMJY requires enormous manpower and IEC capacity, particularly in the initial phase of implementation of the program. But unfortunately, neither the government uses trained or specialized agencies in order to undertake the awareness camps, or in order to disseminate, or IEC, in order to take IEC activities. So as a result of which, what happens is a lot of people who are the beneficiary, who otherwise could have used, got benefited. They are left, struggling. They are incurring the same out-of-pocket expenditure which they were incurring earlier. So you'll see when we summarize, just to give an idea, though 100% of the beneficiaries, they should have been enrolled, they should have given the card, the entitled beneficiaries, hardly when we talk to them, hardly 9%, 10% of the people, they are aware of the scheme, particularly in a state like Bihar and Haryana. Whereas in a state like Tamil Nadu, relatively the awareness rate was very high. It was primarily because the scheme was already running as a state scheme for more than 10 years. So, and particularly you will see in the southern state, they know their entitlements. They are more educated, they are more aware, and they are demanding. So that is something which is a stark difference, which you will see when you compare the eastern states and the southern states, or some of the northern state and the southern states. So it's not only the awareness was major problem, but sometimes what happens, even the identification, registrations. The one of the limitation, or which most of you or those who are working the areas, you might be knowing, the beneficiary was, we have used the SECC data set, which was collected in 2011. So using 2011 data set, which was when the data was collected, the SECC data set was collected, or a household survey was conducted. The purpose was not to use these particular kind of surveys for benefit, in order to use these welfare schemes. So unfortunately, you will see sometimes when the household surveys were undertaken, the households, they might have registered the beneficiaries by their nicknames. And when now you ask them to get their Aadhaar cards, the Aadhaar card name is not matching with the names that are appearing in the SCCC data set. And unless there is a if there is a mismatch, you cannot able to make any changes, and you can't even though you are one of the entitled beneficiary. So these are some of the supply side constraint. Designated shell with requisite skill set for the IEC activities. Hiring aid agency to localize the IEC materials is absent. So whatever the central has given, they are, unless we contextualize, unless we localize, what people can understand in UP might not be possible, or they might not appreciate it if you use the same material in Bihar or in northeastern states, or in Orissa, or could be in Telangana or Tamil Nadu. So it's to our surprise, we conducted a similar, for the same PMJY, we conducted a survey in 2021, hoping that things might have changed. But to our surprise, even today, you would see we have conducted a household survey of close to the 4,000 households, of which 3,465 households, they have cards, but you can see the level of awareness about the feature of the scheme. Even they are not aware that the card is portable. So you can, if you are traveling to other states, or if you're traveling to other district or other part of the country, you can, this card is portable. Hardly 28% of the beneficiaries, they're aware of this particular provision. Coverage period, hardly 31% they are aware of that it is covered for yearly, and they are given 5 years. So none of the dimensions of coverage, even the 5 lakh coverage amount, hardly 80% of the household, they are aware of that. So nothing much has changed between in 2019 and 2021, even after 2 years of time gap. So we were trying to find out what are the other challenges that we encounter in order to reach or move towards the universal healthcare or health coverage. Another problem that you will see often in the health sector is the purchasing mechanism that we adopt. We never do a strategic purchasing. Strategic purchasing, when we talk in economics, we have to minimize the cost. We have to decide what to buy and how to buy and from where to buy. Basically, these are the 3 questions that we, even in +2, when we are the first course in economics, when we are taught that these are the 3 questions that we try to answer. Unless we take a conscious decision about what are the services we are going to buy, and what are the goods or the drugs and other equipments that we are going to buy, and where we are going to buy from, and who are the providers. So it's basically the Department of Health, you will see there's, though strategic purchasing we have been talking about for more than a decade, even today, many of the officers in the Department of Health, they might not even understand. Most of the things happen like, it's like a pro rata basis, or it's like what we did last year. Incrementally, you make the changes and do it. Though there is no zero-based budgeting, and there is no systematic analysis of where we are going wrong in order to improve equity, in order to improve access, in order to improve efficiency of delivery or the quality of care. So these are some of the major challenges that we encounter. Some of these could be because of the governance structure, or it could be because of the issues or challenges related to governance. Again, which you will see typical to the Indian system. It's a federal structure where you will see particularly health is a mixed list. So both the role of states and center are involved. So one of the most important strengths, as well as challenges of governance in health, is a distribution of responsibility and accountability between the center and the states. And unfortunately, you will see often the state and the center, they are not in the same page, which we do encounter, face when we listen, or when we talk to people, or observe the that particular narrative which you will see in the newspaper or news channels. The institutional framework sometimes not only the structure, but there is a complication, but also within the institutional, the framework, sometimes the framework, the bureaucracy and the cadre, the implementing agencies and the controlling agencies, they are the bureaucracy as well as the directors. There is always you'll see a different conflict of interest, and it could be because the bureaucracy that they are not going to be there in that particular department for long. Sometimes they do not able to understand, they do not appreciate the ground reality, or there might be some difference of opinion between the directorates and the secretaries. Role of Panchayat Raj institutions, again, we have seen often we have not able to explore the potential of the Panchayat Raj institutions, the community participation, the involvement of the local leaders, local elected representatives, or local leaders. I think that is something which many of the states that we have analyzed, the more or less the similar kind of observations we have or issues we have come across. So improving accountability, because we need therefore to improve these issues, or to minimize the issues that we are facing. We need to increase the horizontal accountability as well as vertical accountability through better monitoring, grievance redressal systems, and program evaluations. Many states, many often we do not evaluate the schemes for, again, various reasons, which are beyond, of course, our control. Involving communities, which are, again, we have, say, underestimated or we have not, say, exploited the potential of the community power. And more important, the professionalizing management or incentivizing the performance. So these are some of the, unless we professionalize the management, there is always, you will see the doctors or paramedical staff, they might not be equipped to undertake say basic management. So for example, if you take the medical officer who is a young graduate from a medical college, if you ask them to manage a public hospital or a hospital, they might not be equipped with the management practices. They might not be equipped how to manage or maintain even the day-to-day records. So basically what we're talking about when we try to analyze, use a framework for analyzing governance of health system, I think there is an importance of public sector management, there is importance of civil society and political accountability. I think that this is something which is important, and many literature, if you see the literature, this comes often as one of the important variable which we need to highlight. If there is a political buying, if there is a political support or patronage to a particular sector or scheme, definitely it is going to achieve the target without any hassles or with less constraint or bottlenecks. Similarly, we have to even sensitize our citizens, and we have to do a sort of formal oversight of the institutions like independent effective judiciary, legislative oversight, independent oversight of institutions, local participation and community empowerment, something very important again, decentralization with accountability. Of course, we have decentralized many things, but accountability is something which we have to strengthen. So these are some of the things which we are talking about when we say moving towards the universal health coverage. So right now, currently, if you see, we are somewhere at the red dot. The current situation is most services are paid for by individual household. As we said, 65% of the expenses are borne by the households as out-of-pocket payments. If you want to move to universal health coverage, where most of the services are going to be provided to households free of charge, or most of the services free of charge to all the populations, it's a long way to go. Even if you say the near future, if you want to achieve some services being delivered free of charge to all the population, it requires at least the government expenditure. Government has to increase manifold its expenditure, its allocation to the health sector. So do we have the much needed fiscal space? When we say fiscal space, it refers to the capacity of the government to provide additional budgetary resources for the desired purpose without jeopardizing the sustainability of its long-term financial positions. It's not like we take a loan and try to fund the sector, because we also have to see the sustainability of the particular interventions and schemes of the financing mechanisms that we adapt in order to increase this fiscal space. Generating fiscal space for health system, thereby achieving universal health coverage, which is, of course, we have been highlighting and is the foremost objective of the United Nations Sustainable Development Goal. From 2015 onwards, we have been talking about the UHC. Past studies argue that resource-poor economies like India often struggle with lower fiscal space for health, and which leads to a poorer health system. Again, we have enough literature. So basically, we can see there is a linkage between growth, fiscal space, and health outcome. Hoping with the growth of the economy, our fiscal space is going to grow. And with the expansion of the fiscal space, hopefully the government is going to have the ability to spend more on health, which is going to improve the health outcome. Because all these things are, as you see, are in a way interlinked. So we studied the fiscal space using, again, a simple equation. What is our capacity, expenditure, and what are our revenue, capacity to earn money. So right-hand side talks about the sources. Fiscal space can be generated through the 4 sources, common sources, which we talk in public finance, taxes and borrowings, grants, and other sources of revenue. Whereas on the left-hand side, we talk about the expenditure. The expenditure could be non-interest, government non-interest expenditure, GT, or it could be non-discretionary debt interest payments. So we are concerned how much we are spending government non-interest expenditures, which are, of course, one of the, and therefore the second equation, we see how much the government is spending on health expenditure, which is...
Sorry, Professor Das, I think that equation seen is not, the equation slide is not seen.
Is it moving now?
Yeah. Yes.
Okay, could be, is it visible now?
Yes, please.
Okay, so this is the basic standard equation, which identity which we use in order to study the fiscal space of the economy or the government. So what we did, we studied what kind of fiscal policy measures which various countries they've used, and what fiscal space for health or channels which the countries have used in order to prioritize. Because one of the major challenges which you will find in India, though there are interventions, which of course I'm going to show, not yet it is being prioritized. So unless we prioritize the health sector or the health, it would be very difficult even to get support, financial support from the government. So that is something which you would see always the prioritization is more important than anything else. So fiscal space for health, we can see how much revenue we are able to mobilize for the health sector. Not necessarily, because even sometimes we have cess for education, cess for health, or even we can impose which we call taxes on tobacco, etc., in order to raise the space for health. So revenue mobilization, prioritizing spending, and capital receipts, all these are different sources of expanding the fiscal space for health. So we have talked about what do you mean by how the revenue mobilization can be done, and what do you mean by prioritizing spending. So basically, prioritizing spending is reduce non-development expenditures, and we have to improve the targeted of development expenditure. So these are different methods that we can think of in order to utilize the money appropriately and efficiently and effectively. That's precisely what we are talking about. So we, of course, again, if you see the Indian context, we be it the central or government or state government, the sources of revenue mobilization between center and state government if we see the trend over the years, so here, of course, I have shown you from 98, 99, from to 2021, more or less if you take center tax and non-tax, it is more or less this, in 98, 99, it was 70 to 30, whereas in 2021, the tax component has increased, whereas the non-tax component has significantly decreased. So it is now 87 to 13% if you take the ratio. Whereas you take the states, it is tax, non-tax, and the central taxes and central grant. It is again more, you will see the central tax share and central tax share more or less is same over the years. So it has moved from 22.8% to 24.6% in the last say 30 years. Last 20 years. So total revenue as percentage of GDP. So we have estimated the numbers. So the point here, what we want to, we have done the analysis because of the paucity of time. I don't want to go deeper. So you'll see over the years from 98, 99 to 2021, if you see the percentage of expenditure, revenue expenditure on medical and public health, or family and welfare, or be it water and sanitation, hardly things have changed. So it is in 98, 99, it was 4.8%. In 2021, it is 4.8%. Initially, of course, it decreased in the beginning of this particular 2000 up to 2009-10. It was slightly reduced, and then again it has picked up. But again, we have reached the level where we were in 98, 99. Family welfare, it's again the same 0.9. And slightly it has reduced in the first 2003 to 2005, but again we have increased, but again the level is same as what it was in 98, 99. Water supply and sanitations, it has rather declined from 2.4% to 1.3. So the major concern is because of the financial situation of the government, because of the total internal debt and loans and advances which the state governments and the government of India uses. It is something which is very difficult for a state like India to increase its fiscal system. Now the question therefore is how efficiently we are going to use. I think therefore there, as an economist, we have to see how I'm going to use my resources in an efficient manner. So internally, if we use the resources efficiently, that itself would be a sort of a getting more, we can able to offer more services than what otherwise we could have offered. So the major things, we also have done the analysis whether there is any change by regime bias. Of course, we are apolitical when we talk about the regimes, but just for the sake of understanding, we thought of whether there is any change by because about what we are talking about, the political patronage or political support. So you will see it's more or less now because of pressure on the economy to increase the expenditure to 2% of late. In UPA 2, it has slightly increased, and from UPA 2 to NDA 2, if you see, we have reached from 0.7 to 1.3. But then you will, this 1.3 is certainly not good enough to even reach the moderate or the full UHC. So as therefore the challenges are going to be, of course, again, if you see, we have many fiscal space commitments the government, successive government, they've made, and to some extent there were prioritizations, but then the space, the expenditure, if you compare the expenditure with the health prioritization, it is not basically matching, it is not forthcoming. So I think in 2018-19, as we discussed, the introduction of the health and education. So some kind of specific tax structures or taxation policies or targeted taxation policies are something which are wanted, which we need in order to improve the fiscal, the space that is available for the health sector. So therefore, just to give an overview and summary of what we, so not only when we are talking about optimal use of the existing resources, we have to improve the uptake of the services which are being delivered by public sector. We have to increase the uptake of various schemes that are being introduced by the government by increasing the level of awareness through ICT activities. We have also to improve the utilization of the social health insurance schemes. And also there are multiple schemes that are running in the country at this moment. Convergence of all these social health insurance schemes are going to minimize the cost, and it also going to optimize the coverage. And as we discussed the fiscal space, we have to think about how optimally that tax is going to be. Tax reforms where collection of health specific tax, higher excise duties on tobacco products, cooking gas subsidies to poor people, tax administration reform we need to think of, all those which are going to improve the delivery or the implementation of the schemes. So basically what, just to summarize, what is important is on the one hand, we have to increase the demand side or strengthen the demand side factors. And on the other hand, we also have to do a lot of streamlining on the supply side, because these both the demand side and supply side we have to target so that the utilization and efficiency is going to improve without bothering much about the fiscal space, because in the near future we do not see even increasing from 1.7 to 2%. If we go by the trend, it will take at least another 10 to 15 years. And the amount of money, if we don't, unless we improve the efficiency delivery system, it would be very difficult even to reach, reduce the out of pocket by another 10 percentile, to bring it down to 40-45%, or to improve the coverage and utilization by another 5 to 10%. So this is just, I wanted to give an overview of the dichotomies and inconsistencies or distortions that we find in the health system. Thank you once again for giving me this opportunity, and I will be happy to take a couple of questions. Of course, because of the paucity of time, I couldn't able to do justice. But if there are any questions which we can take online or offline, please, I will be happy to talk to you even after this lecture. So thank you very much.
Thank you so very much, Professor Das. Nothing less was expected of you. I think it was a rich, fair, very, very informative, and very critical. I mean, it was not from starting with like preliminary sort of idea about this sector, the challenges, but I think you really went much deeper and sort of laid bare several challenges that a developing and a populous country with a lot of poverty has been facing with a sector like health. So before in fact, I myself, I have a few things to ask, but I will not ask now. We have some time, in fact, for questions, and so anyone in the audience may ask, maybe briefly, but then questions or comments or any observations, please. So the floor is open.
So in fact, the audience can put the question on the chat box or in question and answer window. But so before they pose the question, I would like to ask a question. In India, I think like what is the approach that we are going to take? Whether it will be insurance-based approach or strengthening our public health care? Because what I observe now, say for example, in Orissa, for a long time, did not accept Ayushman Bharat, but then now because that was they were telling that it is insurance-based policy, but now government of Odisha has also moved towards insurance-based policy, that Biju Swasthya smart card. But so how far it is good, because internationally when we debate between UK versus USA, everyone appreciates the model of UK, that is basically strengthening the public healthcare system and getting it for free. In fact, I have seen like how the AIMS functions, and so for example in Odisha, when the public healthcare is provided for free, a lot of donation in funding. So when we were talking about the funding, I was also thinking like a lot of donations are also coming from different sources, whether it is corporate social responsibility or even individual donations from multiple sources. A lot of fundings can come. So what is your response, like, in Indian context, what would be the appropriate model?
Okay, just to respond, thank you very much for the question. I think it can't be either or. So it has to be both, because one or the other is can't be a sort of solution. Even if you see suppose if you take the public sector, one of the major challenge of the public hospitals or public sector facilities where even though facilities were available, people were not utilizing. Suppose if you take any data, whether it is NSSO data or an FHS data, public were hesitant to go to public facilities. Could be, I think, again, all the reasons we don't buy, but that is the perception. So we have to go by the perception of the patients. So it could be because of quality, or it could be because of long waiting time, or it could be because of the way they are treated. So you'll see the utilization is hardly around 30-35% in the public facilities. Now, on the one hand, government is opening the facilities, but people are not willing to use. So therefore, the approach which was adopted is to introduce the social health insurance scheme, so that because the objective is to offer services. Now, if people feel the quality of services are poor in the public facility, therefore access is becoming limited, let us empanel private facilities for availing the services, right? So it's basically, you see a lot of, even the public facilities are also empaneled in the social health insurance schemes. The purpose was, so it's a sort of incentive. Now it is also a sort of subsidizing. You can compete with the private hospitals. You can say improve your branding, and the money that you generate can be used to upscale or to strengthen the infrastructure, because sometimes we complain that our infrastructure is bad, outdated, poor, or quality is not good. So if we raise money by treating the patients of the social health insurance scheme, that money can be used by the public facilities to strengthen their own structure. So if you leave it to entire social health insurance scheme, first of all, the network of private hospitals, we do not have sufficient network of hospitals. So people in the rural areas, people in the suburban areas, they will not be able to access quality care if we leave it entirely to the insurance sector, right? And so therefore, the government has to play a mediating role, and also has to ensure that the government is there, the facility is there to give you the required care when you want. And we have to change the perception, because it's the same, because we have seen, and now there are, if you go to some of the public hospitals, or particularly the district hospitals, the wards which are created for the Ayushman Bharat schemes, they are no inferior or worse than some of the private hospitals. So that's the kind of investment which some of the hospitals did.
Okay. I think there is one question from Professor Mitali Chinara. Can you compare the central scheme with the state scheme, that is the Biju Swasthya Kalyan Yojana?
Yeah, I think it's more or less the scheme and are the same. It's because that there are states, for example, if you take Orissa, or if you take Tamil Nadu, or Andhra Pradesh, because they had, or they later added their state-specific schemes, because they did not want to be part of the central Ayushman Bharat PMJY scheme. Because it's again more, I would say, political. So but therefore, otherwise the intention is the same, the coverage is more or less the same, and the direction is more or less the same. I don't see there is any difference between be it Odisha scheme or be it Tamil Nadu, where we call the Chief Minister's Insurance Scheme. They are primarily meant for the same purpose.
I think Dr. Pradeep Panda, he is asking, there is a trade-off between committed program expenditure एक second. And health sector allocation, how to address the trade-off?
Well, it's like as economists, that's always, we know there is a trade-off. So we have to see, basically, it's a return on investment. If you ask me, if I will say, we have to assess where we are going to get the best. It's not just the short run ROI, but we have to see the long-term investment, return on it's basically a long-term investment. So what is the ROI which we are going to get if I undertake investment in the health sector? It's not only the life and livelihood, because we have to take into account all the direct and indirect benefits, and then we would able to assess how much we can trade off or divert from one sector to the other sector. But when there is a fiscal constraint, we know it's a which bullet I'm going to bite. But then so we have to take a call and see, judiciously decide, so that the impact is going to be better when we see the social impact.
The next one is from Professor Jagannath Lanka. He very much liked your presentation. He says that thanks a lot to educate us. It was a very impressive talk. So he's asking about the Jan Aushadhi Kendras that help more rich people compared to the poor. So your comments on that.
Well, I say don't disagree, particularly when it comes to the Jan Aushadhi Kendras. But if we see again, it's a relative term. It's not that the top quintile or quartiles, they are going to the Jan Aushadhi Kendras. I think if we compare, it is the middle income households or the lower income households, they are the people who go mostly to the Jan Aushadhi Kendras. So therefore, again, the experience varies from state to state. Suppose if we take the state of Rajasthan, because the other day we were part of the presentation and we were listening to their experience. There it is working, the impact is, I would say, it's very good, and they are highly satisfied the way it is benefiting the beneficiary of the household. And as far as government is concerned, it doesn't matter if it is benefiting the household, because if we take even the hospital, not necessarily, if you take particularly the district hospitals or medical colleges, you will find often it is the rich people who get admitted to these because of the connections and because of other things. But then when we see households are as households, we want the households to get benefited, even if it reaches benefits the desired 40-50% or reduces the out-of-pocket expenditure of the needy people. I think the objective is to a great extent met.
There is another sort of concern expressed by Dr. Pragya Monalisa Sahu. So she's sort of wondering whether by not going for PMJ and sort of like having Orissa having its own one, which has a less coverage in terms of number of districts. So she's wondering whether Orissa has been a loser.
No, I don't think the scheme, there is, as I told you, there is no difference. The only thing, if you here the state government is spending everything, there, suppose if we use the PMJY, it would have been 80-20. 80% would have come from the center and 20% would have the money would have to be from the state. Now, when you do it state specific, you don't get much grant or assistance for that particular scheme. But otherwise, the benefits are more or less the same, and even the packages and the prices that are being set by the PMJY, the states they can make use of that, and they get benefited from by using the same packages.
No, I think her one concern was like whether BKSY covers hardly 10 or 11 states outside Odisha, that too very few hospitals. So whether a central scheme would have given them a better.
Yeah, but the portability is something which is going to be the major concern, okay. Because unless you link it to the PMJY scheme, say when suppose if I'm traveling and if I fell ill in others, or if I'm migrating, or suppose often again you will see particularly Orissa, a lot of people, they migrate to neighboring state for most of the time, because particularly the lower class, 50-60% of the time they spend in Kerala or Tamil Nadu or Surat. So unless we have, because they can't get the scheme of these specific states. So when they carry the cards of say Biju Swasthya card, that might not be somehow it is not aligned, so they might not get benefits if they are traveling or they are staying in the out of Odisha. That is definitely a major concern.
Dr. Niyati Padhi is asking, how about bringing the patient and the doctor to a common platform, since there is a clear-cut urban-rural divide between rural and urban India? Shouldn't the health insurance companies take this extra responsibility, since we are going more digital in the health sector?
Yeah, I agree. Actually, again, some of the private hospitals through mobile or e-health, because they are using the e-health platform, and using the e-health platform, they have clinics in the rural areas, or they have connection with the local clinics, so that they can take advantage of the scheme. But going forward, yes, it should be it is the responsibility of these private hospitals or the hospitals to get patients. In fact, in Tamil Nadu, they were asked to conduct camps. So when you conduct camps in the rural areas or in market, or during, for example, weekly markets, where a lot of people, they come from the rural areas or hilly areas, tribal areas, if you conduct camps and then detect cases, and suppose if you have some serious cases, they are going to be sort of recommended, sent to hospitals, advised to seek care from the local nearby hospitals. Definitely, I think that is part of the social responsibility, and that also some hospitals, they use it to get more patients from the remote areas.
I don't see any more questions, but still, if anyone wants to ask something, can post. But I think there have been quite some questions. I think your talk really generated a lot of interest. So let me also take the advantage of this particular occasion. So I think I was sort of wondering, like, whether I think also partly linked to what Amarendra was asking. Like, so we have made this. I mean, there is a concern about finances, or sort of what you sort of described very nicely as this fiscal space. In fact, there have been some critiques, as you may have known, like someone is saying that, okay, you sort of make announcements of, okay, there will be renal dialysis facilities in every district. And then someone who estimated found that the whole cost would be much more than the total cost of the whole program nationwide. So when we are sort of making this kind of statements, and there may be a need for such sort of diseases and maybe health expenditure. So how do you see the role of the private sector? Meaning, like, because this is a huge contrast, as you say, like on the one hand, we are having all these schemes, and you are saying that the perception has not changed, or the government hospitals are not well equipped, they are in far off place, and quality is not good, etc., etc. But I'm ready, because it involves health and nothing less than that. So I'm ready to pay more and get a better service. So what role you visualize for the private sector, if I may ask that?
Yeah, two things. I think when the government fixes the money or provisions, they create a provision for different schemes. And as you rightly pointed out, the number of cases and number of hospitals, if you multiply, the total amount is going to be more than what the provision was created. So basically, when we do the assumption, we know that everybody is not going to seek care. And we see the trend. Based on the trend, only even suppose, for example, 30-35% of the beneficiaries are utilizing. So when the utilization increases in subsequent budgets or some subsequent years, the provision is going to be increased. So therefore, initially they set a lower amount, And when it is utilized appropriately, and 80% of the money which was approved is utilized next subsequent year, they will definitely, it will be improved. But I don't think anybody will be denied when these schemes are announced, or it is not going to be told because the budget is over, approved budget is over, so therefore you will be denied of the service. I think that scenario, at least we have not come across in the literature, or at least with our interaction with administrators or the policymakers, we have at least not come across such a scenario. But I'm sure that's how the estimations are being done, assuming or taking how much percentage of the people are going to use these schemes. Second, yes, we want the quality care. Quality is the major concern of many of the households. And that's where the private as well as public. It's not that public, some of the district hospitals, they are giving better quality care than even some of the private hospitals. So it's not that all the private hospitals, they give the better quality. So I think that's again something perception. It's how we are being treated. Sometimes because we should say, when you approach the doctor, if the doctor listen you carefully, it's like half treated. Right? If so that's the amount, how much responsive you are. That is why we are talking about the system has to be responsive. You have to take interest. You have to give the care or the importance, because everyone wants to be respected. Unless you respect, unless you care, unless you give them the recognized space to them, they will not come to us. So that's basically we have been trying and educating people to be more responsive. But yes, quality is definitely a concern. Even there are low-hanging fruits. So for example, if you make the wards clean, it better lighted, and even water facility or etc. Drinking water is provided. So some small things, if they take care of, you'll see quality is going to improve a lot. It's sometimes basically what happens is a generic drug versus. So if you go to the public hospital, because they buy on bulk and get a generic drug, we think the quality. It's not quality. It's not the. Yeah. I think we have to educate them. It's not the quality, but it is a perception. Yeah. But yes, we always want for quality. I don't mind paying a premium.
There are two more questions. I think you have really provoked the audience. So there is one more from Dr. Govind Pradhan. So he's also asking more or less a similar linked question, like whether there is sort of way to do some kind of a fiscal adjustment between the center and state is sort of possible to finance this universal health care. And what kind of my concern is health is there in the state list, and the recent trends of fiscal relation in India is being highly centralized. So he's wondering whether the state and center should devise ways by which they can sort of support each other financially to make these programs work.
Well, yes, always there will be, when we talk about the public policies, or when we talk about this federal structure, there will be issues like what we are encountering. Again, it's not that money is not diverted, or it's basically when we talk about the division of money between center and state, it is based on the finance commissions, which are being based on the recommendation of the finance commission. But I think if the central government, because it's whether it is when it becomes health, whether it is state or it's the health of the country, it may be some of the implementation is going to be done mostly by the state, but definitely health is the concern of both the state and the center. So when it comes to, therefore we are saying it's how much whether it's state or the center, how much importance they are assigning to the health per se. So the moment they recognize the importance of health, they will come together. There will be some frictions, and of course, when there are two different political parties, those kind of jerks we will feel. But I don't think that is going to jeopardize the country or the economy or the sector.
And Dr. Jitendra Kumar is asking whether there should be a regulator, strict regulator for the private sector in this health, because people generally, he thinks that the better doctors and better services are available in the government sector. So whether the private sector be regulated strongly.
It is partly regulated, I would say. It's not that we are leaving. Suppose if you take the councils, MCIs and registrations, through registrations, etc. They are being regulated. Even, for example, what kind of packages to be given and what kind of services to be given. I think those are standardized to a great extent. Standardized. Even if you take the social health insurance scheme, when the hospitals are being empaneled, they are being inspected, and they have to be registered, and definitely they are being regulated. It's not that because again, health is such a sector where you will see the asymmetry of information. So that asymmetry of information, it's like the doctors, they are aware of everything, whereas the clients or the consumers or the patient, they are not aware of anything. So that asymmetry, lack of symmetry, information asymmetry is one of the major cause of concern. But otherwise, I think with the kind of regulation, of course, the collusion will happen. That's there not only in the health sector, that is there everywhere. And of course, like CII, so we have, so we have agencies, we have rules and regulations which are to oversee whether somebody is not misusing all the practices, or whether it is drug or whether it is practices. I think they are definitely regulated, but more stringent regulations are required.
I think we have a large number of questions. I have just one small clarification. It's not exactly a question. Like, I'm sure you know about this Jan Swasthya Kendra, the GK movement in Bangladesh, started by Zafrullah Chaudhary in 1970s. So I was just wondering whether that is a much better or a more, let's say, broad-based, inclusive strategy for a country like India, particularly rural India, let's say. So how does GK compare with, let's say, this project, the PMJY and similar schemes?
More or less, they are working the similar manner.
Okay.
So it's a similar manner. We have the generic drugs, and which are most often used by the people, but maybe sometimes over the counter we were buying from the pharmacist, or the general drugs which are being prescribed by even the small clinics. So I think those are the drugs which are available, so that at least the pharmacy shops, they do not exploit. Yeah. And these are available at a cheaper price. So if you want those who know that quality is one and the same, at least some facilities available so that you can buy and minimize your expenses.
Thank you so very much. I think we have really taken a lot of your time. It was a great learning experience, and many, many thanks. It was an excellent talk. And as so many questions came, I think that in itself suggests that you made an excellent presentation. So let's all clap for that. And many thanks. So you are very much part of Orissa Economic Association. We'll be seeking your support, but then for some formalities, let Amarendra say a few words. Amarendra, please.
Yes, no, it was really very educative talk, and basically an important issue, because there has been quite a lot of demand for providing universal healthcare, and the debate between center and state, and the financing issues. So you have covered everything, and so thank you so much for accepting our invitation and educating all of us. And and I know that actually, as a director of the institute, how busy you would be, and particularly such a big institution. But in spite of all that, you accepted our invitation and spent your valuable time and knowledge you have shared with all of us. And although I did not announce in the beginning, We have recorded this, and in fact, we are going live on the YouTube channel of our Orissa Economics Association. I should have announced it at the beginning. Thank you so much, sir, for this wonderful talk. And then I'd also like to thank Kshetra sir, the president of Orissa Economics Association, for moderating this association. Sir has been always encouraging for doing all the activities, and so beautiful managing the session. And although now Dr. Satchidananda Pattnaik is not here, the son of Professor Kshetra Pattnaik, who was with us, although he has become quite senior. In fact, he's a live member of our Orissa Economics Association also, and he's a student of Delhi School of Economics. So he also joined with us. And then most importantly, all the participants and the members of Executive Committee who could join with us, I thank all of you for your valuable time. With this, we may conclude. Thank you so much. Thank you so much.
Thank you very much.
Namaste.
Thank you very much.
बहुत